Good morning, good afternoon, depending on where you are. My name is Tom Campbell, and I am the Program Manager for the Traumatic Brain Injury State Partnership Program and the Administration for Community Living here at the U.S. Department of Health and Human Services. I'm a middle-aged white man. I have almost no hair, short cropped beard. I wear glasses. I'm wearing a checkered shirt and a dark blue blazer. Behind me on the orange wall, there is a watercolor painting, and off to my left, a bookshelf. We want to thank everybody for joining us for today's, I lost my notes. There we go. Thank you for joining us for today's TBI session, TBI Tuesday session, titled Justice for All, Serving Individuals with Brain Injury Across the Justice System. This is the fourth of 5 TBI Tuesday sessions in observance of March being Brain Injury Awareness Month. We're doing these in lieu of ACL's normally in-person annual TBI Stakeholder Day. We are excited actually for this opportunity. We wouldn't have taken it if not for the current pandemic to have such virtual sessions. The time that we've been able to spend and the content we've been able to share with you all has greatly expanded because of that. And it also has allowed more TBI stakeholders to attend. Today we had almost 400 people registered for this webinar. The webinar is hosted by the TBI Technical Assistance and Resource Center, the TARC, T-A-R-C. The TBI TARC is funded, of course, by the Administration for Community Living. And all the webinars are free and open to the public. So if this is your first one, great, welcome. We've got one more next week. It's not March, but it feels like March. So we're going to do one more in the first Tuesday in April. One of the ways we're doing these this year is that the TBI Tuesday sessions we're highlighting the work of the ACL-funded TBI State Partnership Program grantees and the work groups they're working within. There are 9 different work groups that the TBI grantees are operating in addition to doing and creating and strengthening their services and supports for individuals with TBI in their state. These 9 work groups cover a broad area of topics. The very first week, we covered underserved populations and the work group that was working on that. Then there were sustainable partnerships, and last week there was return to learn and return to play. And this week, we are going to be talking about criminal and juvenile justice, and that work group will be leading today's session. During today's session, we also are going to highlight some federal partners and initiatives. Today, we will hear from Kyle Smitty from the Special Litigation Section of the Civil Rights Division of the Department of Justice, and from Reggie Herter from the Policy Research Associates and the Substance Abuse and Mental Health Services Administration, SAMHSA, the SAMHSA GAINS Center for Behavioral Health and Justice Transformation. GAINS stands for Gather, Assess, Integrate, Network, and Stimulate. We'll also hear from 2 individuals with brain injury and their experience in the justice system, Jennifer Scott and Cheryl Kempf. Next slide. All right, webinar logistics. That's what we need to talk about before we can get started. Participants to this webinar will be in listen-only mode, so you will not be able to speak. If you need to speak or ask a question, or please use the chat feature in Zoom to communicate with the hosts. There will be a Q&A time after every speaker, a time to ask questions if there's time. We are going to try to stay on our schedule, but we do want to give you all the most ability to have time to answer questions, to ask questions. We will address these questions there will be a slide after every speaker, so watch for that. But you don't have to wait for the slide. Go ahead and put your questions in chat, and you can figure that out. You can go ahead and put your questions in chat, and we'll get to them as we can. We will be live captioning the webinar in English and also providing an American Sign Language interpreter who you hopefully see on your screen there. If you don't see the captioning, move your cursor and there'll be a button, an icon that pops up on the bottom of your screen that you can click on and the captioning should start. If you have any questions or problems, technical problems with that, go ahead and ask the question in chat. This live webinar is interactive. So you will have an opportunity to respond to polls and other questions as we move through the day. Next slide. Feedback. Yes. After the webinar, you can send follow-up questions and feedback to this website, TBI, at hsri.org. Please note, we will not be monitoring this email during the webinar. If you need assistance or have a question during the webinar, please use the chat feature. A recording of this webinar and every other webinar, along with the PDF version of the slides, will be available on the ACL website. The first recording is already available. The first recording from the first TBI Tuesday a few weeks ago. And I believe the link for that was just put in chat. So that's terrific. So now we want to go to the poll. The first poll, there it is. We want to know who's here. So you'll see the poll pop up on your screen. Click as many of these as you want. How do you self-identify? You'll see lots of different options there, and I'll give you a few minutes to go through those. Person with a traumatic brain injury or other disability, family member, self-advocate, peer specialist, social worker, case manager, researcher, service provider, organization employee, or government employee. Always a popular one. In a few seconds, Connor will close the poll. We'll give you a few more seconds to respond, and then the poll results will pop up. All right. We have government employee at the highest percentage, 48%. Then we've got service provider, organization employee, social worker, counselor, and care manager, about 30%. Family member or of a person or a friend of a person with a traumatic brain injury at 22%, and then self-advocate, and then person with a TBI, thank you for being here, and peer specialists, thank you all for being here. Researchers at 13%. All right, now let's get to the business at hand. I would like to welcome Peter Bespikos, Executive Director of the Rehabilitation Hospital of Indiana. The hospital partners with the Indiana State Department of Health, one of our TBI State Partnership Program grantees. Peter will introduce himself and talk about today's session and get things started by introducing the other speakers. Peter?
Thank you, Tom. Again, my name is Peter Bespikos. I'm with the Rehabilitation Hospital of Indiana and have our resource facilitation and neuropsychology departments under my purview. And we are, of course, a partner in an ACL grant, which has been a wonderful experience. Part of that experience is what's coming to you today. And I'm going to give you an overview of the agenda and then hand off to the first speaker. But before I do this, I realized I'd forgotten to describe myself. I'm a more or less middle-aged white male with very blonde hair, beard, and glasses, and I'm talking to you today from my office. The work group whose work is being highlighted today and being embellished on with some other outstanding speakers was the Criminal Justice Work Group. And the product they developed is truly extraordinary. You'll learn a lot about it today. It's a criminal justice Intercept model. It allows you to look at every section of the criminal justice system, analyze how your subject matter, in this case brain injury, would work or interact with the criminal justice system and begin to plan strategies. So you'll have the normal types of things that we normally have in a seminar of this nature. You have some outstanding presenters who have brain injuries and have overcome them. You will hear scientific evidence about the prevalence and risk of brain injury, and you will hear about legislative successes. the Intercept model is the thing that draws this all together. For those of you who are not familiar with it, as you look at it and you look at your criminal justice systems, it will provide you a very clinical way of assessing where your opportunities are and where you can begin to build solutions. So if you would keep that theme in mind as we go through this, that should provide some context and some cohesion to an outstanding and varied series of presenters. And with that, I'm going to introduce my colleague and next speaker, Dr. Lance Trexler, who is also with the Rehabilitation Hospital of Indiana.
Thank you, Peter. Thank you very much. Hi, my name is Dr. Lance Trexler. I am more than a middle-aged white male with precious little brown hair, for which I attempt to compensate with a mustache, but it doesn't really work all that well. And I have on a red and white striped shirt to bring some festivities to this event. So thank you very much for your interest. Can I get my first slide, please? Yeah, and maybe there, okay. And the next one, please. Thank you. As Peter said, I'm with the Rehabilitation Hospital of Indiana, Indiana University School of Medicine. And this presentation comes to you because we are the lucky recipients of an ACL grant. Next image, please. So let me just give you a brief outline of what I'm going to go over and very quickly here. First is the issue of the prevalence of traumatic brain injury in the criminal justice system. And unfortunately, some of the ethnic disparities are inherent in these data. We'll briefly touch on why is brain injury a risk factor for engagement with the juvenile justice or criminal justice systems. And then we'll talk about some preliminary evidence regarding the effectiveness of resource facilitation to potentially reduce recidivism. Next one, please. So these are startling data, and this was why, as a neuropsychologist, after spending 40 years in a rehabilitation hospital or clinic, I felt compelled to get involved in the community and start looking at how do we impact recovery for people with traumatic brain injury long after their injury. 60% of people that are in the criminal justice system, in prison rather, will screen positive for a history lifetime exposure to traumatic brain injury, as compared to 8.5% in the community. So it's a striking finding. Next image, please. Then also, when you look at youth, this is another statistic that concerns me a great deal. This is a study of 508 adolescents who were inpatient hospitalized for psychiatric reasons. And what they found, to get to the bottom line, was that the traumatic brain injury during childhood and adolescence increased the risk of any criminality by almost 7 times, increased the probability of a diagnosis of a, quote, conduct disorder, end quote, by almost 6 times, and increased a concomitant involvement with the criminal justice system and a diagnosis of a conduct disorder by almost 19 times higher than for people without childhood exposure to traumatic brain injury. Next image, please. So traumatic brain injury is a significant risk factor. 83% of those people that are involved in the criminal justice system that had lifetime exposure to traumatic brain injury, 83% of them had it before their involvement with the criminal justice system. Next, please. So, as you might guess, there are also significant ethnic and cultural disparities. And I'm going to go over these data pretty quickly. I believe you'll have these slides available afterwards. First of all, the incidence is higher for, particularly we have data on Hispanics. The rate is 262 per 100,000 as opposed to 200 per 100,000 for the overall population. Injury risk factors associated with minority status are things like poverty, dangerous work and residential environments, demanding physical jobs, among others. And also, despite similar functional status at discharge from inpatient rehabilitation, assuming these folks get to inpatient rehabilitation, they're more likely to have poorer functional outcomes at 1 year, even when you control for severity of injury, for example. Next image, please. So Black and Hispanic people are significantly less likely to receive inpatient intensive rehabilitation, even if you have Medicare. And so there are biases at work here. And I already mentioned that functional outcomes are likely to be less optimal. Caregivers of people who are Black or Hispanic express more burden, spend more time in caregiving, and have fewer met needs as opposed to their white counterparts. Black and Asian Pacific Islander folks are likely to have increased depression over time, increased depression as compared to whites. The good news is for Hispanics, it appears that depression decreases over time, but not for Asian or Pacific Islanders. And Black people with TBI have lower life satisfaction. So we need to address these issues in a very specific way in our healthcare systems. Next, please. And these are references for those of you who'd like to see them later. Next, please. I'm going to briefly address the neuroanatomy and the neuropathology of traumatic brain injury. This is puzzling to courts, it's puzzling to government officials, it's puzzling to people with brain injury and their families. You can't see traumatic brain injury in the vast majority of cases. People look normal, they have normal CAT scans, they have normal CT scans and MRI scans. And the reason for that is, as can be seen in this first image in the middle and the top, is that the tissues, brain tissue gets torn in a traumatic brain injury, and the axons of cells can be torn apart, causing disconnection in the cells themselves. And so a metabolic abnormality, as well as a microstructural abnormality, causes the kinds of impairments we see. On the image on the upper right is a histology, microscopic examination of brain tissue. And all of the little brown areas there are torn axons in that particular segment or the particular piece of brain tissue. In the bottom image there, you can see in the circles, there's some little dots that when diffuse axonal injury does show up, which is not often, that's what it looks like on a CT scan. And they're scattered throughout usually the white matter of the brain, which is like saying that there's a disconnection between your cable and your computer or in your telephone line. So information processing is slowed and disconnected in some respects. Next image, please. What this looks like with a new technique called diffusion tensor imaging is a loss of connectivity. On the left-hand side of this image, you see a major pathway in the brain connecting the front and the back of the brain. And then all of the fibers that come out of that network or that highway, if you will, connecting different brain regions. And on the right, what you see is there areas where those fibers have been lost due to diffuse axonal injury. And so the impact is on connectivity. And so it's for these reasons that many people with traumatic brain injury don't have an impairment of intelligence, but they have an impairment of being able to access and utilize all the different information processing systems that they ordinarily would have. Next image, please. So the impact on this has to do with then just ultimately the organization of behavior. So in the back part of the brain, we have centers that manage vision, and we have hearing and the sense of touch in the back. Deep in the middle of the brain, we have systems that drive our feelings and our emotional reactions, and also our drive, our intent, our purpose, and what we intend to do. And it's called the limbic system, and it's deep in the brain. But ultimately, it's the frontal lobes that organize our behavior and according to our goals and according to what's going on in the environment. So it regulates our emotions. It helps us focus what we should pay attention to according to our goals and according to what's socially adaptive at the time. Unfortunately, with traumatic brain injury, then because of the disconnectivity, the frontal lobes often don't have the opportunity to get the information they need, or they're impaired in their own functions, affecting then the adaptability of their behavior. So if we go to the next image, what happens is with traumatic brain injury is we often see frontal lobe injuries, and it's pictured there in the pink area of the brain where the circle is. Also on the CT image on the right there, you see what a bruise or contusing looks like in the frontal lobe region. And the behaviors that result from that are impulsivity, of doing things you know you shouldn't do. And it's a dissociation, it's a disconnection of what I know I should do with what I actually end up doing. The folks with this injury can look hyperactive or hyperkinetic. They can be irritable. They can be euphoric and jocular when they shouldn't be, like standing in front of a judge. And cognitively, they have difficulties maintaining their focus, maintaining cognitive set. And so people misinterpret all of these behaviors and label those with psychiatric kinds of labels, not understanding that the origin is in fact neuropathological and neuroanatomical. So if I can have the next image, what this looks like practically and functionally is people will have deficits of attention. So they look like they're not paying attention. They look like maybe they're not interested, when in fact that may have nothing to do with it at all. Of course, memory deficits are ubiquitous following this kind of injury. And so criminal justice personnel may think that they're blowing them off, or they're not paying attention, or they don't care, when in fact the very systems that manage memory have been impaired. The neurobehavioral changes go along with the frontal lobe impairment. So you see people going from 0 to 10 in their anger in a very short period of time, or mood swings that frequently get mislabeled as bipolar disorder. And these are the behaviors, of course, that lead them into incarceration and increased incidence when they are incarcerated. The frontal lobe issues also result in making inappropriate jokes, inability to inhibit drug use, and the like, which gets them in trouble with law. And then the most important, in a way, the executive function deficits, because these lead to a person's difficulty carrying out what they intend to do. And that may be as short as and as simple as saying what they want to say, and they may have trouble organizing their thoughts and the words to say what they want to say, but they also may have trouble doing that over a week or over a month or over a year. So they may say, I want to get a job, but have significant difficulty organizing their behavior to achieve that goal. Next one, please. So there was now, fortunately, some work beginning to emerge on how do we help folks with traumatic brain injury, and an important study was done in Pennsylvania by Dr. Nagel and his team. They provided resource facilitation for some individuals that were in a maximum security prison. They screened those folks, and 75% of them screened positive for possible brain injury. So they did some further evaluation, neuropsychological testing, and found that of those 75%, 70% or 74% had persisting cognitive impairment, And quite remarkably, on average, they had 3.8 brain injuries each over their lifetime. They provided resource facilitation in this descriptive study and found that the recidivism rate at a year was 17%, which was really quite good compared to the baseline. And of those that got resource facilitation, 50% of them were competitive employed. Next slide, please. Resource facilitation is a service navigation process. It's also to educate the patient and the family, and it's also to promote collaboration of care and to help providers know how to provide care to individuals with traumatic brain injury. Next, please. So we've done a number of studies on resource facilitation at Indiana, thanks to ACL, and found significant improvements for even patients 10 years post-injury, where those who received resource facilitation returned to work 64 to 70% of the time, as compared to the control populations where they're 36 to 50%. We've also found a significant decrease in the level of disability associated with the injury with resource facilitation, and a significant decrease in survivor perceived need for services, and a significant decrease in the services being received. And the next one, please. And these are just references. Next, please. This is a study that we've submitted on the impact of resource facilitation for recidivism. This was a randomized control trial that we did with the support of the previous ACL grant. To summarize quickly, if you combine rearrests and reincarceration at 6 months and at 12 months, what we found was that if you got resource facilitation, you were 13% of those folks recidivated at 6 months versus 36% that recidivated that did not get resource facilitation. And at 12 months, we found that if you got resource facilitation, 32% recidivated, as opposed to 53% for those that did not get resource facilitation, both of which were hugely significant. So next, please. Thank you. This is a study also that just got funded that's going to take place in Florida. I'll just briefly mention it. It's the first randomized controlled trial of resource facilitation in juvenile justice. And that'll be done in collaboration with individuals in Florida and in Indiana. So next slide, please. Thank you very much for your interest, and I'll defer to the team if there's time for any questions at this time.
Thanks, Lance. We do actually have a couple really good questions, but we are just running a few minutes behind schedule. So I suggest that if it's okay with everybody, we move on to Julie. And I've captured these questions that hopefully we can ask at the end, if that works for everybody.
Thank you very much, everyone. Appreciate your interest.
Hi, everyone. My name is Julie Myers. I'm a program administrator with the Pennsylvania Department of Health. I am a Caucasian female with long brown hair. I wear glasses. I have brown eyes. I have the blur effect on in my background, so you can't really make out anything anyway, but it's just a couch and a blank wall. I'm just going to give you a brief overview of the Criminal and Juvenile Justice Work Group and just some of the highlights that have come out of this. So the participating states in our work group include grantees on the Administration for Community Living Traumatic Brain Injury Grant. So those include Alaska, Colorado, Indiana, Pennsylvania, and Vermont. And what's kind of cool about this group is that, we started out just the grantees, but there's just so much interest and passion in this work that we quickly evolved to also include what we're calling the full collaborative, which includes representation from Alabama, Arizona, Iowa, Nebraska, North Carolina, Oregon, and Washington. The purpose of this work group was to provide mentorship in criminal and juvenile justice, and as well as to develop products for criminal and juvenile justice. And the major products that have come out of this work group include the criminal and juvenile justice workforce competencies. Every ACO, not every single group, but many of the groups, the work groups on this grant have been charged with coming up with competencies for the workforce that is likely to interact with individuals with brain injury. So of course, our focus was on what individuals working in the justice system, it would benefit them to know about brain injury. So that's been a major effort. As Peter has already alluded to or introduced us to, the Criminal and Juvenile Justice Best Practices Guide has been the other major product, but my colleague Karen is going to tell you all about that later on, so I'm not going to go into detail about it here. Next slide. So we've also included some highlights from some of the states involved in our work group and the full collaborative. I'm not going to read them out loud now for the sake of time, but just know that this information is here, and these presentations will be made available, and this PowerPoint is available for download as well. So if you're kind of interested in some of the really high level snapshot of what's going on in our different states in the world of criminal and juvenile justice, you have some highlights here. So you can kind of skip through all of these highlights. And I think that concludes my portion of this presentation.
Great. I don't see any questions in the chat just yet, but I think something that might be helpful, Julie, is do you anticipate the work of the criminal and juvenile justice work group continuing? And if so, how could interested parties participate?
Absolutely. One thing is those of us applying for the new grant cycle will likely be trying to continue some of this work. And we definitely have kind of thoughts and plans in the work to continue on the momentum of the guide, the best practices guide. So we have, we'd really like to publish that and make it just disseminate it as broadly as possible. So we are in discussions about how we can follow up with that and capitalize on that, or possibly hand that work off to a new work group under the Administration for Community Living grant, if that's an option. So we're all very passionate about this work and definitely would like to continue to move forward with this. It's just a question of kind of everybody's funding and time and does that answer your question?
I think so. There's another one that came through when Lance was talking, but I think all of us could probably try to address as well in this context. When we're talking about the 60% of people in prison positive for a history of brain injury, how, at least in your experience, Julie, or with the work group, how do you think people should go about trying to explain that to systems? I think it's a pretty high number, and for those that are hearing it the first time, it feels like it's almost unbelievable. And so just in your experience in doing this work, how do you kind of get that buy-in and that understanding from the system?
Sure, that's a great question. And any of my colleagues, feel free to jump in. I can say from Pennsylvania's experience, having that statistics has been helpful for opening doors and kind of establishing the need for brain injury education and training. I mean, when you see numbers that high, it's very easy to conclude, okay, this does affect me, this does affect my setting, this affects my workers. I would say kind of on the negative side of that, there's, I don't know if I want to say resistance, but there can sometimes be this sense of being overwhelmed. Like, this is such a huge problem within our justice system. If we start to tackle it, it's going to be opening a huge can of worms. And, you know, thinking about this from the national perspective, you know, if we really pursue this work, very quickly we'll start to get into questions of, you know, the ethics of having so many individuals with brain injury, you know, with cognitive issues in prisons and other justice system settings. And it kind of gets to be, you know, almost like a disability rights issue. So there can be, I think, it's you know, showing people the data and the information is great for opening doors, but just counseling that it can also be overwhelming for settings that are already very under-resourced. I don't know if any of my colleagues have anything to add.
Julie, if I might, this is Peter Bispicos. We see two problems that judges face on a regular basis with numbers that high. One is when you say 60%, you identify a problem for which there are currently no resources. So when you talk about being overwhelmed, that's part of that problem, is that people get overwhelmed because they see the problem, they don't know what to do with the solution. The other challenge that we see, and I spent 7 years as a prosecutor in Indianapolis, and my friends asked me, who are still there, asked me the question, well, okay, does this mean that these 60% of the people didn't have the intent to commit the crime? And so the prosecutors are nervous about that, because how do you properly do your job under those circumstances? And I think the answers to those questions are not, that last question is a case-by-case basis. But those are two other barriers that we've seen talking to judges.
That's a really good point. In Pennsylvania, we've also, it was a little bit tricky for us to find kind of the point of entry into the system, for that same reason, that there was concern that if we started screening for brain injury too early in the process, it would impact sentencing, and which ostensibly shouldn't be a concern for our juvenile justice system, as it is not meant to be punitive, it's meant to be rehabilitative. But that's something that we've had to navigate as well.
Great. Julie, we do still have a few more minutes left in this section before we move on to the next speaker. Are there any highlights from the states? I know we kind of went through those slides, but were there any that stood out that are worth sharing just in the next, you know, like 3 to 5 minutes?
I mean, this is one of those things that if I picked out one, I mean, everyone's doing such incredible work that I wouldn't feel right isolating one without, you know, covering everybody. But maybe this would be, maybe Lance can take a couple of questions so that there's less of a gap between his presentation and being able to answer.
Sure, that sounds great. And the slides are available for everybody if they're interested to see some of that information. Lance, there was a question that came through previously. How can people with traumatic brain injury who exhibit these challenges, these difficulties, be properly supported so that they're not pathologized or labeled as having mental health illness if that's not the case?
So if I heard you correctly, Liz, I think the question was, how can they be accommodated? I'm sorry.
How can they be properly supported so that it's not labeled as something else?
Yeah, so I think the first issue is screening for lifetime exposure, and a number of states have started to do that on a routine basis. I think the research would say that probably the best instrument to do that is the Ohio State University Traumatic Brain Injury Identification Method. And if people want to know about that, they can email me. The first issue is knowing about it. The second issue is then using accommodations to, as we would for any difficulty in this respect. And so there are a variety of sources for accommodations out there for people that can help them with their cognitive difficulties and serve to help them adjust better to the criminal justice system or to deal with them in court situations as well. So I think that's the first issue, is identification and then appropriate accommodations.
Great, thank you. One quick question you might be able to answer. Where can we find information about TBI population and arrest? Do you know more about that specific data?
I don't know that I've seen data on arrests. I do know we did some screening in the Indianapolis, Marion County courts, and we found, again, anywhere between 50 and 95% exposure to TBI. For example, the Indiana Veterans Court, we found a screen positive rate of 95%. But I haven't seen any data for just arrest at the time of arrest.
Great, thank you. And then one more question before we move on. I don't know if this is for you, Lance, or for Peter. Can you speak more to culpability and TBI screening?
Well, that's a really interesting topic, and Peter should weigh in on that also. So I think if someone has a stroke and their left arm doesn't work, I don't think they're culpable for that. I think if you have a traumatic brain injury and you have cognitive and behavioral impairment, it becomes an ethical and it becomes a legal issue in a variety of ways. But are people responsible for their own behavior when they have a frontal lobe injury? I don't know. I'll have to defer to the legal experts and to ethicists, but it is a disconnection between intent and behavior. It's a disconnection between knowledge and behavior. So I think where we draw that line depends on the individual, but first we have to know they have a brain injury. Second of all, we have to evaluate them to know what the effects of that brain injury are. And then third, understand it in context of what they're being charged with.
I could add about 30 seconds in on that. This is a topic that could probably consume maybe a semester in law school. But one of the ways you look at intent when you're trying to prove it is you look at the complexity of the crime. And the simpler the crime, perhaps there's less direct evidence of intent, the more complex. So shoplifting versus running a Ponzi scheme, a person who's successfully running a Ponzi scheme wouldn't be caught. But I mean, if they were caught, probably not a brain injury interfering with their judgment. If somebody was disorderly or doing something that doesn't require a lot of thought, then it's harder to assess that. And so you got to look at it really from two levels. One is, do they have the intent to commit the crime? And if they do, does the crime affect their culpability? And that could impact sentencing. So that's where you might see maybe a smaller or no jail in preference for a therapeutic option at sentencing. These are all wide open questions. I think we have a blank slate on this one because this issue is still so new.
Great, thank you. So I suggest we move on to the next presenters.
Do you want me to start the video here?
It's already going.
Oh, it is.
Is it? I'm sorry, I don't see it at distance, Jennifer. Is there
The line.
Oh.
Yeah, I don't know if folks can hear me. This is Laura Trexler. There we go. There's my
I'll
video.
take you off. Okay.
I'm going to go ahead and open up as my name is Laura Trexler. I'm from the Rehabilitation Hospital of Indiana. We're a subcontractor to the grant lead state agency, which is the Indiana Department of Health. And I have gray shoulder length hair and I wear glasses. In the background, you'll see a small bookcase and a fireplace. I am going to be working with Jennifer Scott. I'll be interviewing her and raising some questions that she will be responding to. So Jennifer, if you can come on board now and describe yourself, that would be great.
Hi, my name is Jennifer, and I have long blonde hair, blue eyes. I'm in with the same office as with Peter, and I'm very happy to be a part of this.
Very good. Thank you so much for being here with us today. I'd like to ask you a few questions about the history of your traumatic brain injuries, some of the struggles that you have experienced, the treatment that you received, and what your life is like now. So I'm going to open up with Jennifer and I, just to let the audience know, we've had a variety of wonderfully enriching conversations, and so I know a little bit about her. I understand, Jennifer, that you've had 3 traumatic brain injuries and you experienced changes in yourself and your behavior with all 3 of those. You mentioned to me that the first 2, you were aware of changes in your memory and concentration and attention. But the last one, the one in 2015, was the most significant. Could you start, please, by sharing with us what happened to you in that accident? What was the accident?
Yes, the last and final traumatic brain injury, I was the passenger on a motorcycle in 2015. And for some reason, the driver of the motorcycle hit about a 1-foot curb which was extremely high in the middle of oncoming traffic. And the bike and the driver rolled on top of me and my head hit the curb very hard. And so that's how the last one came about. And I was unconscious for several days in the hospital. They were going to do surgery on my carotid artery. I broke all my ribs, had some aneurysms pop up.
Can you describe for us some things about how this most recent injury affected your behavior, your mood, your thinking skills in a way that was different from what you had experienced with the other 2 injuries?
Absolutely. Back up here so you can see me. What was the question again? I'm sorry.
No problem. So you had described to me that the first 2 injuries, you were aware of memory and concentration and attention problems.
Yes.
This 3rd injury brought about some even more significant changes in you. Can you speak to that a little bit?
Yes, I ended up and I didn't understand why. I was like walking as a zombie in my life. I had no recollection I was in a fog, and I had shoplifted 6 times and got caught 6 times. And I had a very harsh judge, who didn't believe me about anything having. All the hospital diagnosed me was a concussion. So they didn't treat me for a traumatic brain injury. But how I felt was I saw a video of myself and I looked like not me, and my daughter was there, and she said, that is not my mom. I was fully unaware of what I was doing, making these bad decisions, because I've never been in trouble with the law in my life. And, you know, that's how it affected me, and it affected my work. With memory problems, I still have horrible memory, of short-term memory. I don't have any smell, and tasting food, I have to doctor it up to taste it.
Thank you for mentioning that part about the smell and the taste. We had talked about that a little bit before, and as we had learned from some of the reports that we reviewed, this might be an indication of some orbital frontal area damage, and Dr. Trexler just spoke to the issue of orbital frontal damage and how that can impact behavior and regulating behavior. I think Dr. Trexler, you quoted, sometimes people do things that they know they shouldn't do, and there's a disconnect between intent and behavior. So after this injury in 2015, there were things in your behavior that you found puzzling, and you didn't understand why you participated in some of the things that you did.
Right.
I'd like to move ahead just a little bit. This went on for perhaps about a year, and something changed. The Rehabilitation Hospital of Indiana has an individual who's identified as a local support network leader. And this individual goes out into the community and offers brain injury education. And she had the opportunity of talking to the Indiana problem-solving court staffers. And in this presentation, she discussed brain injury, the impact on behavior, and she shared information about how to screen for a brain injury. There was an individual in the audience who screened you for brain injury. And this was, as I mentioned, about a year, I think, after the injury. And through that screening, she made the referral to the Rehabilitation Hospital of Indiana. This person was from the mental health problem-solving courts. Can you tell us a little bit about what happened when you were referred to the Rehabilitation Hospital of Indiana?
Absolutely. Yeah, I want to make a note that they tried to put me in the mental court. I interviewed for that, and that they said they approved me to be in the mental court. However, they called my former employer, and he said, no, she's not mentally ill. And based on that, they changed their mind, and I had to go through the regular criminal system. And what was the rest of your question? I'm sorry.
Sure, no, this is wonderful information that you're sharing. It's very helpful. You had mentioned to me that when you were evaluated with the Rehabilitation Hospital of Indiana, that was a really pivotal time in your life, because I think you quoted, I can quote you, and you said something like, now it had a name, now I understood. Can you speak a little bit more to that?
Yes. I had no idea what was going on in my life. I was going through a lot of things: job loss, depression from being hurt so bad and laying on my couch where I can't move. And I had was referred to Rehabilitation Hospital and took a full day of examinations and shared my story. And had I not been able to find them, I don't know where I'd be today.
I think that you had mentioned to me that it really changed your life in many ways, and your interactions with family and support parties. And thank you for saying if that hadn't occurred, you're not sure where your life would be today. Because one thing that we discussed together was, I think you said if that hadn't happened, you imagined it would have been hard for you to change your behavior patterns.
Exactly. Yes.
And there were a variety of individuals that you highlighted when we were talking that you felt were instrumental in this pathway. Of course, the person who did the brain injury education, and then the individual in the mental health problem solving court who did the screening. You talked a little bit more about some other parties that were instrumental in this pathway. Would you like to do any kind of shout out to, for example, attorneys or judges or other providers that helped you along the pathway?
Yes. One thing that got me back into the job industry where I had a nice paying job like I had before was Audrey Bonner. And she, I believe, was the occupational side of it, to where she would provide me with tools on how to keep my job with my memory so I don't have Post-it notes everywhere. And big shout out to her, to RHI, and definitely, you know, my family and my husband.
Absolutely. So we have individuals, providers from a rehabilitation hospitals. We have attorneys, a judge, vocational rehabilitation. The woman that you named, I believe, was from vocational rehabilitation.
Yes.
Your spouse. So some very important people along this pathway, along with you, who've done a lot of awfully hard work to be where you are today. We're almost close to the end. I'd like to ask if there's any important message that you want to share with others?
Yes. I would like to start some sort of legislation here in Indiana that these tests are done when the prosecution is talking with someone like myself. I'm hoping that by speaking today, it can help someone else.
You have mentioned to me that you feel like more brain injury education in the court system would be valuable, that people need advocates right from the start.
Yes.
All really good points and much appreciated. I think it might be nice to close with people because there was a lot of turmoil that we highlighted a little bit of. But I think it would be really nice to close with people on how you experience your life now. I think there's some really wonderful things happening, and it would be great if you could share those.
Well, after 17 years of being single, 4 years ago, I met the man of my dreams. And he really took an understanding and learning the process of what I went through. Because, I mean, when I met him, I had an ankle bracelet on. And, you know, he overlooked it. And my family, some in the beginning didn't believe me until RHI reached out and actually spoke with my family to help them understand what was going on. And I'm expecting my first grandbaby this June. So I'm very happy. I started a part-time job. And I feel good and normal to be back in the workplace and provide for my family.
Well, I want to thank you so very much for your time today. I really appreciate it, and I think you have some very valuable messages to share with everyone.
Yes, thank you so much.
Thank you, Jennifer and Laura. There weren't any questions in the chat, I'll say, but just several people saying thank you so much for sharing your experience.
Do that.
Hi, everybody. This is Regina Herder, and I'm going to start now. I think it's my turn. And I am so happy to be with you. I'm going to talk with you about the Sequential Intercept Model and walk you through that. To describe myself, I am a middle-aged white female, long brown hair, blue eyes. Today I have on a black shirt with a necklace that's silver and also has an image in it. It's called the Botswana Dancer. And then I also have a colorful shawl on. And in the background, I have the image of one of our logos from Policy Research Associates, which is the agency which I work for. If you'll go to the next slide, please. And my work with you today is to talk with you about the sequential intercept model. This model is going to be less specific to brain injury than what we've been talking about so far, because we are just catching up with this. So I'm going to talk with you about the intercept model from a bigger point of view, and a way, though, to think about your justice system. And many of you on this may already have mapped out your process of looking at the intercepts between mental health and substance use and the criminal justice system. And we would invite you to consider kind of that same process in looking at brain injury. We've also done mappings around women-specific issue, around homeless, opioid use disorder, and right now I'm in the middle actually of designing one specifically around disabilities, including acquired brain injury. So basically the theory behind it, Patty Griffin and Mark Munitz, who actually come out of Pennsylvania, so shout out to all the great work that's been taking place in Pennsylvania, was really to look at how do people go through the system. And there's kind of this very kind of predictable way that people go through the justice system, both juvenile and adult. And that there's also different intervention points or intercepts where we can promote access to treatment, where we can create deflection and diversion from the system, and also to make sure that there is timely access to services and that we're identifying the needs of folks as they're going through. So if you will go to the next slide, please. So this particular slide has the elephant on it, and you probably all are familiar with an old folklore about 5 blind men who come across an elephant, each one touching a different part of the body and describing it. And so you can imagine that somebody at the tail might describe it very differently than somebody at the tusk or the trunks or the big ears or the very large body parts of an elephant. And what you see on this particular slide are different parts of the system of jail and initial hearings and prison and mental health and substance use and arrest, all those types of things, and that they don't look very sequential at all. In fact, they look like they're kind of all over the place. If you go to the next slide, what we see with the intercept model is it really helps to kind of organize that process. And in the intercept model, what we see are intercepts that go for intercept 0 through intercept 5. And I'm going to break down these in each one, but there's a couple things I want to say here. One is that the information largely that I'll be providing you today is about what are the types of things, the types of players that are at those different intercepts. I invite you to really think about, so what is it that you can do? Who needs to be educated? Lance and Peter and Jennifer and Laura and everybody have talked already about the importance of identification and then using that information to help have meaningful interactions with folks who are within the justice system. So I will try to identify key parts of the system of who you might want to be doing a little bit of training with. I also want to just kind of acknowledge that in this particular process, sometimes I'll talk about intercept 0 and 1 is almost being somewhat interchangeable. They are both distinct, but they also have law enforcement and 911 call centers who are very, very much a part of both of them. And intercept 2 and 3, we often think about them together as the initial part of coming into the court system. We'll look at some stuff in jails, but also first court appearances, and intercept 3 looking at dispositional courts. So there was just Jennifer was just speaking that she was screened for mental health court, but wasn't allowed to be in it. We'll talk a little bit more about that. And then what's also taking place inside of jails or prisons, or if we're talking about the juvenile system, we might think about residential treatment facilities, or we might want to think about kids aging out of foster care at that particular time. So thinking about people making big leaps back into the community, which here we call reentry. I tend to think about it as transitions, and then into community corrections or community supervision, which is generally done by probation and parole. So want to kind of walk you through this. I also want to point out that intercept 0 and 1 for the juvenile justice world, that's where we would also, especially intercept 0, look at schools. We'd also look at school discipline, school resource officers that might be in that particular place. But Intercept 1, we'd also will look at, things like hospitals and emergency services and fire and other kinds of first responders. And then also looking at things like recreation centers. So there are all kinds of different areas of work that we can get information to around brain injury, but also have some really good wins in helping folks understand what's going on and how to best help and support people. If you will go to the next slide, that would be great. So why is this important? And again, this is really just around more what we're calling behavioral health, really looking at mental, serious mental illness in particular of folks going through the justice system. But what we see is that folks are more likely to be homeless. They're more likely to have co-occurring disorders, persons require a variety of services. And there tends to be a lot higher cost. When we did a study in Colorado, it was about $9 a day for persons with serious mental illness. And so that doesn't even bring in other kinds of disabilities such as acquired brain injury. They're more likely to have disciplinary problems. And a lot of times that's because we don't understand how to help accommodate, identify and accommodate folks who have brain injury or serious mental illness, substance use disorders, disabilities. More likely to be unemployed, more likely to have psychological impairments, including extensive trauma histories. And that trauma history there, we're talking about more emotional trauma, where we see both men and women, males and females, having both current and historical trauma histories. And folks tend to have longer lengths of stay in the justice system. And that is sometimes because of case processing, and sometimes it's because of behavioral issues, or of course, in general, we see a high rate of competence that's being raised. If you'll go to the next slide, please. So at Intercept 0 and 1, again, as I said, there's oftentimes we think about these things both as being separate, but also really diving off of each other. If you'll go to the next slide, please. So I'm not going to go through all the things on the slide. I wanted you to have some information. If you'll forward to the next slide. Thank you. But basically, in Intercept 0 and 1, it is probably your greatest opportunity to deflect. So to try to keep people out of the system. And that is because the goal here would be to have people get access to services in Intercept 0. So that law enforcement doesn't need to be called. And if law enforcement is called, that they have the information and that there are services that are available for people to be able to be diverted, or deflected to services. So part of that is training with 911 or PSAPs, as they're also known, but also if your county or municipality has 211, and then of course the 988 national line that's coming in, but also to make sure that you're including in training crisis and warm lines. We want to make sure that there's integrated services across all your different services. So primary care, FQHCs, or federally qualified healthcare centers, health workers, community health workers that may be working with them, but also the hospital, emergency departments really are up to speed on brain injury. Looking at CCBHCs, which is really an integrated community-based care center that looks both more like a primary care as well as mental health and substance use treatment, but also making sure that everything is integrated with homeless services and that there's a direct connection to jail. So jail might seem odd to put that into Intercept 0, but we have to think about what's taking place for the person at Intercept 0, because a jail should be seen as a point in time going through the justice system if necessary. Again, our goal is to try to deflect or divert folks from jail, but to be able to make sure that if folks do end up in a jail situation, that they're getting the right kinds of services, medication consistency and continuity, those types of things. We really want to be looking at community-based outreach. Again, recreation centers, making sure that they have training, making sure that folks who are doing information desk in public spaces, whether that be at libraries or that be in a municipal building, that folks have training around brain injury, training around mental health, substance use, and other disorders. We have to really, in this day and age, telehealth is going to be a huge part of this when, especially in Intercept 1, when we look at that, it is a key factor to have police being connected, at least virtually, to mental health providers or providers that can help give them information so they can make good decisions. You will also see in Intercept 0 things called co-responders. So co-responders is having a clinician, so usually a mental health clinician that is rolling with police out in the community responding to calls, wanting to make sure that that clinician, or sometimes in places it might be a peer provider, that's a person with lived experience in the justice system and living with usually mental health, but that person being able to also have training around brain injury. And today, in today's age, what we're really seeing as a growing and exciting field of not just looking at response to 911 calls done through police, but also done through what we call alternative health responses. And that alternative health is often going to be a medic, either an EMT or a paramedic, with, again, a clinical responder or a clinical responder and a peer. And again, wanting to make sure that everybody who's responding to persons who are in crisis with training around brain injury and other disabilities. So those are really important. Also looking at homeless outreach teams and making sure that in your community, homeless outreach teams or homeless response teams also have training around brain injury. And homeless and housing is a big part of Intercept 0. So working with your shelters, working with your homeless providers, making sure that folks have information again around brain injury. So there's a lot of things that take place in Intercept 0 and 1. Again, the whole goal here, most people call it crisis response, but I always look at it as there's 4 different parts of crisis response. One is pre-crisis, so what was taking place before the person went into crisis are the things that we can be doing to help them have access to things like WRAP, which is Wellness Recovery Action Plans, or other kinds of supports, and peer supports, brain injury supports in this particular case. And when somebody's actually in crisis, to make sure that we are doing all we can to deflect them from the system and deflect them right to services. Across the country, you're going to see a lot of what's called crisis stabilization centers. That might be a secure facility, but it will be usually without restraints. Or it might be something that's called a walk-in center. It might be a peer-run center, often also known as a living room model. But all of those different kinds of settings need to have training around ABI, and so that they can both do screening, but also make sure that they can accommodate folks. At this area of crisis with that deflection, we also want to make sure that there's that next step of stabilization. So what are we doing to make sure that we're getting folks, not just keeping them in crisis, but releasing them, or they're coming back into community, or we're deflecting them or diverting them to services to help support them. And then, of course, long-term recovery is that next part. If you can go to the next slide, please. I should also say that hospitals are, again, a big part of that. And what I'm finding is that more and more emergency departments really need to have information to look at brain injury. Intercept 2 is really getting into the initial detention, initial court hearings. If you'll go to the next slide, please. And I put this slide in here just to kind of give us some baseline. So we have about 2.1 million people nationally who are incarcerated in the United States. About 7 million of them are under services, which are probation or parole. Most of those, we'll talk more about that in Intercept 5. But when you look at jails, local jails have about 19% of the population of state and federal prisons. The biggest difference is that local jails, the average length of stay is for a sentenced population is usually less than 3 months. For a pretrial, in most jails, about 60% of the population in jails are what's called pretrial, meaning that they are sentenced population. They have not yet been sentenced. And so they are waiting trial. And so we are, in my work, try to doing all we can to get people out of a jail setting. And in state and local prisons, those are usually sentences that are longer, most often longer than 2 years. If you'll go to the next slide, please. One of the things I always want to be mindful of is what we call high utilizers, or also known as familiar face. And so there is a population within the justice system that continues to come through multiple times. And they tend to also be folks who are high utilizers of the justice system in general. The average age in the justice system is 35.7. Our familiar faces or high utilizers are often older than that particular population. They are often also experiencing homelessness, and in particular chronic homelessness. Anytime I use the term chronic homeless, understand that that also means that there is a disability in addition to meeting the federal guidelines of homelessness. And they also tend to have very high levels of substance use disorders. And oftentimes what is most prevalent and what we're seeing in the justice system is that substance use disorder. It's very often alcoholism, but we are missing other types of disorders, whether it be mental health or brain injury and other disorders. We also see a very, very high rate of populations within the homeless world who have suffered head injuries because of falling and also being assaulted on the streets. If you'll go to the next slide, please. So one of the things that we want to look for is really trying to divert folks. So before I've used the term deflect, which is trying to keep people from coming into the system at all by getting them to services in the community and not making an arrest, not making a custodial or an in-person arrest. And again, those co-responder and those alternative health systems, really what we find there is that usually less than 4% of co-response based calls or interactions result in even a ticket. And so it really can be a great model for deflection from the system. If folks are coming into jail, then what we want to try to do is to divert them to services, or to try to have the least amount of intervention in the system, unless it's for violent charges or where they really need to be involved in the justice system. And a couple of things that are taking place here at Intercept 2 is the first court appearance. And so that is really the first time when judges and defense attorneys and prosecutors are going to get involved in the justice system. And so it's really training. So getting information to folks at this level, and so they have an awareness about brain injury, that there is a screening process. More and more, a lot of defense systems are using social workers, clinical social workers, to help come up with what might be viable diversion options. And so making sure that those clinical social workers, as well as the attorneys, have training around brain injury. Another big part of this particular population can be jail population reviews. And so that's usually a process where prosecutors and defense attorneys, and oftentimes treatment providers, community treatment providers, get together and they look at who's still sitting in jail and why. Sometimes it could be because people don't have the money to bail out of jail if cash bonds are still being used. But it also can be because of other kinds of issues. And so we want to make sure, again, that we are arming those folks with training around brain injury. We also want to really differentiate between who's there for holds, because that often is going to be a hold either from another jurisdiction, or it might be because of a technical violation. And so in Intercept 5, what you see is probation and parole having technical violations that put people back into jail. And so that is something that we really want to make sure that we're training, again, probation and parole officers on, so it's around brain injury, so that they are not violating folks because they're not able to follow through or remember appointments and those types of things. Competence is also something that really comes up in Intercept 2. And there is an ongoing need. There's oftentimes folks are sitting for many days, months, waiting competence hearings, either through a state system or doing competence restoration in jails. There's a growing presence of community-based competence restoration. And so it's again important that competence evaluators are trained around brain injury and disabilities. And there I'm also really thinking about IDD and other disabilities. And understanding that there are certain kinds of restoration that's not going to take place. So people really have to get more sophisticated at the level of raising competence and making sure that we are not having people in the justice system who shouldn't be there. And that we, again, are having mental health diversion, but also really in mental health diversion, understanding how can we divert somebody who has a brain injury and what are those resources. I always suggest to people I work with that they have a list at ready of all different kinds of disability resources, whether it's interpreters or it's calling your state head injury folks, making sure that peer services, but also places like ARC and Access Living and others to be able to really help work so that we can create viable diversion options. And a big part of jail, again, at this level is trying to identify by data folks who might be there because of technical violations, because that's often a big population that's sitting in jail. And then Lance was talking earlier about persons with overrepresentation, communities with overrepresentation in the justice system. And that is a critical part because persons who are white often have greater access to things like treatment courts. So it's an important thing for us to be looking at. And here I've just listed that as the relative rate index. If you'll go to the next slide, please. In Intercept 3, this gets further into courts, not just that first hearing binding with people being bound over or arraignment court. It's really, now we're getting into really getting to sentencing kinds of options. And so with all of our treatment courts, we want to try to create both sentence options as well as post-sentence options around treatment courts. But it also starts not just getting into the initial screening that takes place at jails. Many jails across the country are doing the brief jail mental health screen, which is just 8 questions. But what we find is that jails are not doing substance use screens, and they're not in general doing acquired brain injury screens. And that is something that our office is really trying to work on to help jails do even just that historical screening that was mentioned earlier from Ohio. If you'll go to the next slide, please. So, yes.
Apologize for interrupting you. I have to be the bad guy here. We're running a little bit behind schedule.
Okay.
Yeah. So I wonder if you want to kind of summarize and then some of the questions we've got, we can hold till the end. Is that okay?
Perfect. Yeah. Let me just talk about a couple of things. So please work with your sheriff's departments and the jail healthcare folks to be able to really do brain injury screening, and then to make sure that they are training sheriff's officers about how to keep folks safe within the jail, both in housing as well as custodial management of folks, so that folks are not being penalized within the system. If you'll go to the next slide, making sure that and so also making sure that everybody's a part of problem-solving courts, has information around brain injury. And if you'll go to the next slide, that this is going to start getting into, go to the next slide, please. Thank you. And so now we're getting into reentry. And that is really thinking about not what's been going on with folks who are in jail, but how are we preparing folks for release. Reentry should also always start when folks first come into a jail setting. It could also, again, be prisons, residential facilities, but also how we're releasing folks with resources and making sure, if you go to the next slide, that there is a standardized checklist where we are asking folks about what's it going to look like for folks to go back into community and be stable. And if you go to the next slide, please, next one also, and one more, making sure that folks are reentering with the simple things like identification, making sure that jails are not releasing people at midnight, which tends to be what most jails do. And then for our community partners, supervision, probation, or parole, again, being trained around brain injury, making sure that there's policies as well as practices to not penalize folks with brain injury or with other disabilities, and really looking at how we're using technical violations. So I will stop there. We can just skip the last couple of slides.
Really great information. Thank you so much. Let's move on to our next panelist, and then we'll get to some of your questions, Reggie, at the end.
Great. I've unlocked my video. I'm waiting for it to pop up. Hi, everyone. I am a white male, young to looking, but middle-aged, with blondish hair, a beard, wearing a white blue suit jacket and a light blue shirt, in a guest bedroom with a bed behind me. My name is Kyle Smitty. I am bringing a federal perspective here. I work at the United States Department of Justice in Washington, D.C., in the Civil Rights Division. I am an attorney. I also have a master's in social work. And I started with my master's in social work and then became an attorney. And I work in the Civil Rights Division and then in the Special Litigation section. And I'm going to explain how that works here. My role on this panel is, it's wonderful to be here and to be a part of this group, and it's really great to go after Reggie, who talked about this sequential intercept map, because it really fits with where I belong in this panel and how I fit into this and how our office fits into this group. If I had a superpower, if our Civil Rights Division had a superpower, we'd be the enforcers. That's what we kind of do here. We enforce civil rights laws. And the Civil Rights Division enforces lots of civil rights laws. So for those who don't know what we do, this first bullet point kind of points that out. The Civil Rights Division enforces civil rights laws, housing discrimination, education discrimination, employment, voting, disability laws. And if I had a marker on me and could write on the screen, I would write the last section of the Civil Rights Division is the special litigation section, which doesn't really tell you anything about what we do, like the housing section does housing discrimination. Well, the special litigation section, in a way, does the sequential intercept map. It works along the sequential intercept map. We do work in the police context. We enforce the rights of people in the who are in corrections, and enforce the rights of people who live in the community. And so I'm going to talk a little bit about those different aspects. And while we don't do work, specifically or particularly about people with traumatic brain injury, we do touch on it in all of our work, or it can be touched on in all our work. And so we're really happy to be here and to let you all know, almost 200 of you now that are here, know about the work that we do. And so I'm going to talk a little bit about and give some examples from that work. So you can go to the next slide now. So I'm just going to talk about each one of these kind of intercepts and the kinds of laws that we enforce, and give an example from a case across the country that we work on. So for police, we enforce the rights of people who interact with state and local police departments. And we enforce this law that's called the Violent Crime Control and Law Enforcement Act of 1994, which is 34 USC 12601. And it allows for us to review the practices of law enforcement agencies that may be violating people's federal rights when they arise from a pattern or practice of violations. So that's a lot of legal speak for, if police are violating your rights and they're doing it in a way that shows a pattern or practice of violating, the Civil Rights Division and the Special Litigation section can go after them. That's the bottom line. And we do that. We do that across the country. One case, and we do it in a way that impacts and includes the rights of how they how police interact with people with disabilities. And those people might be people with mental health or with people with traumatic brain injuries, and people who are in crisis, and how law enforcement should be educated about those kinds of disabilities or those kinds of injuries, to know how to interact with them. So I'm just going to give an example. In Portland, Oregon, we have a consent decree from 2018 where crisis, give the interpreter a second. Where crisis intervention teams are required to be introduced into the Portland police system, so that when a 911 call happens, it doesn't just go to a general patrol officer who would respond without any training, wouldn't know what they're seeing in front of them, but instead it would be responded to by an officer and a qualified mental health professional, or an officer who has been trained on mental health issues, to know how to ask the right kinds of questions and to evaluate the situation so that they wouldn't be responding immediately with force or improperly. And when you look at what's happened in Portland, at least in 2019, the data from that consent decree, it showed that the kind of training and the kind of work that was required was fruitful, and that the reduced numbers of force because of that requirement was showing that force was not being used against people with mental illness when those 911 calls were happening. So that was really great. Another example is in Baltimore, consent decree in 2017, where we required that officers be trained and work with community mental health providers, so they collect data on identifying gaps in the mental health system and come up with solutions and coordinate with those providers to react to those kinds of situations. So I put in the chat a way to look at some of these consent decrees, so you can look at that to see some examples from the ones that I'm mentioning. So now I'm going to move to corrections and juvenile justice. For that enforcement superpower, we enforce the rights of people in state prisons and local jails. We use the Civil Rights of Institutionalized Persons Act, CRIPA, C-R-I-P-A. That's 42 USC 197A, if you want to look that up. And it includes the right to constitutionally adequate medical and mental health care when you're inside institutions. So just because you go into a jail or prison doesn't mean you lose your right to adequate medical care and mental health care. In fact, that's a really big problem, right? You don't have access to those except for the people who are now holding you in jail or in prison. And so we have the ability to go and investigate those institutions to make sure that they are providing people with those services. One interesting piece of that is it often leads to coordination with local health agencies to ensure that people with disabilities are connected to health services upon discharge. So a release, right? So as you're leaving a jail or a prison, that you're getting kinds of services. So an example for that, these are two examples. LA Jails is one example, and Hampton Roads Regional Jail in Virginia is another example. I'm an attorney on the Hampton Roads case and have been for 4 years now. That investigation started in 2016, and in 2018 we made a findings letter, which is shorthand for a report that talked about the need for warm handoffs for prisoners leaving the jail, and found deficiencies in mental health care at the jail based on a lack of adequate treatment planning. And a consent decree was signed by the Attorney General, William Barr, and the jail in 2020 in August, not too long ago, that required medication and in-reach from the community mental health agencies to set up release planning around housing and transportation and mental health appointments. There's still a lot of work to do on the front end of that, but it's a real good model coming out of the United States Department of Justice for other places to look to, that this is the standards that the Department of Justice sets for what jails and prisons should be doing for people who are coming on that part of the sequential intercept map that Reggie talked about. And lastly, I'll talk about, for folks with mental health and developmental disabilities, we enforce the Americans with Disabilities Integration Mandate. So this is the community services kind of aspect. And, this obligates public entities that offer services and programs and activities to do so in the most integrated setting appropriate to the person's needs. So, the result of these enforcement activities increases the availability of community-based services. This could be, crisis services, or the goal of de-escalating crises and avoiding unnecessary police interaction and arrests. An example of this is in Virginia. There is a consent decree that began almost 10 years ago for people with developmental disabilities, which does have some overlap with traumatic brain injury. Not exactly, but there's been some expansion of that to include people with traumatic brain injury. And there's been some successes in that case, and also still a lot of work to be done. But it's shown that they've safely transitioned over 900 people into the community. They've started new programs like crisis responses. The state of Virginia has increased more than 800 people living in their own apartments. And they've incentivized lots of providers to serve more people in the community with challenging needs. So with all of these examples, none of them were specifically directed toward people with traumatic brain injury, but there is a lot of overlap. And we wanted you all to know on this call that, we're a resource, we're, an enforcers, we're a network that looks at investigating these kinds of issues. And it's really great to be here. I really appreciate the time. Thanks a lot.
Thanks, Kyle. That's really helpful information. We are just about due for the break right now, but I want to ask one question that's kind of come up in a number of different ways from people that I wonder if either you or Reggie or anybody else could answer before we jump to the break, just because I'm worried about losing some people after the break. And so I think something that a lot of people are asking and would really like some additional input on is buy-in from this system on basically what's an invisible injury for a lot of individuals. And so whether it's law enforcement or attorneys or jail staff or prison staff, how would you recommend in your world and from your experience gaining buy-in from these different professionals along the way and these different intercepts and that are interacting with individuals with brain injury, whether or not they realize it? And how do you think people on this webinar could learn about gaining some of that buy-in from this world?
Kim, is that directed at all of us?
Yeah, I mean, I think we're up against the break right now, and there were just a couple questions that came in that I think are kind of alluding to that, that these are relatively invisible injuries, and how, when we're talking about law enforcement, for example, how do you get that buy-in, in that part of the model of like, these people are dealing with something that you probably can't necessarily see, but here's how to support them, and it's not an excuse, that sort of thing.
So I think there's a couple things I would offer on that. One is to partner with your community mental health provider, your FQHCs. So those folks who are probably providing services already to folks, and then have make sure that they have information around brain injury, because I wouldn't assume that all of the providers do. And then having them help. So like if you have a mental health provider and you have a mental health court, that mental health provider is probably working with that mental health court. So then they can help engage and really educate the probation officers and the courts. And so I would always look at kind of who your proxy folks are that can be champions, and try to make sure that, again, that everybody has some training on that. Information is really key. The system is just now starting to get their head around mental health. We are a long way from looking at the bigger picture. And what I was trying to remind folks of, and Kyle's comments are so important, because if folks don't pay attention, then those suits can take place. And what we want to try to do is have people really saying, we can do this differently. And it doesn't have to be huge changes. They just have to create an awareness. And then they have to really take a look at what is it that they can do in order to accommodate folks. But I would look at your proxy folks, whether it's, so look at your EDs, so your emergency departments. They can train law enforcement officers. Hey, do you know this person has a brain injury? Right? And so there's always different ways to train that people will hear the information, and then moving to your bigger legislative policies and practices as part of your follow-up. But to me, it's awareness and creating some of your key champions in the first place and understanding what to do different. Kyle?
I'll just give you like a practical example. Like, you know, when I sit in like the Hampton Roads Regional Jail and I'm sitting with officers talking to them about mental health issues, and I'm realizing that officers just don't believe it. Like, they just don't believe people have mental illness, right? Like, you have to start there. So like, I'm not even talking about TBI, which is like harder to see. We're talking about mental illness, and like, people don't believe that other people hear voices, and like having to like push past that and do training where you're sitting with an officer, and the training is literally one officer talking into the ear of another officer and another officer talking to that officer, so that they can start to model, this is what this person is hearing. This person is hearing another voice talking to them. And you have to know that this is a real thing. This is actually happening to them. You can't just blow this off as this isn't happening. And so making it concrete and real, and getting them to believe these are real things that happen. And so giving them examples in their personal life, the people who actually have to, you know, respond and are on the front lines, that's a mental health example. I'm sure that there are good examples that people on this that aren't panelists, but that are in the audience that could talk about, you know, could be in the training about TBI, and giving officers or corrections officers or police officers examples of how to recognize or how to think through what traumatic brain injury. I mean, just listening to Jennifer's story was, you know, informative. And like, if I had officers listening to Jennifer's story, they would learn a lot and start to be aware that, oh, I have to think about this in a different way. That's how we get through to this. I mean, it's not an easy fix. To me, it's the training. It's going to take a long time, and we have to keep educating people.
One last thing on that, that is also several places have reentry committees. They have mental health committees. If they have a justice system planning group, they probably have a mental health or a reentry committee. And so and that's usually multidisciplinary. So making sure that those committees, again, have the training, because the more people start to talk about it, incorporate the language, think about it, the more likely that folks will start to say, oh, I should know more about that. That probably is something that's impacting folks that I'm working with.
Thank you both so much. Really great comments and responses. And I think you're right, Kyle. It really speaks to people like you, Jennifer, sharing your stories. It makes a huge difference. So Dana, what do you think? Should we go to a break?
Yes, absolutely. Thanks, Liz. Thank you to all of our speakers. We are going to go ahead and take our full 20-minute break. It's 2:43 now, so we'll reconvene at 3:03. We'll be playing some music during the break. Also, feel free to step away from your computer, whatever you need to do to come back and be re-energized, because we do have an action-packed last hour where we'll talk about the best practice guide. We'll hear from another self-advocate of lived experience, and then we'll get to a lot of the burning questions that have been coming into the chat here as well. So go ahead and take a break, and we'll see you back at 3:03 Eastern time. Hi, folks. We're going to start to trickle back in from the break. As we do that, just want to echo some of the appreciation that's coming into our chat for our ASL interpreters, and especially to Terry for your rendition of the music here. Much appreciated, and putting a smile on a lot of people's faces here. I think I am going to go ahead and turn things over to Karen Farrington. Karen is with our Colorado grantee, so you've heard from some of her colleagues already on this call, and she is going to talk a little bit about the work that they've done in putting together this fabulous guidebook for people with TBI in the justice system. So I'll go ahead and turn things over to Karen now.
Terrific.
Oh, I guess before I do, sorry, there's a slide here, just a announcement about our last session that'll be coming up on April 6th, maximizing the effectiveness of advisory boards through full participation. So this is our advisory boards and survivor engagement work group. We'll be putting this on, and it is in April. It is not during March, which I know is Brain Injury Awareness Month. We ended up moving this session at the behest of some of our TBI survivor participants who will be a part of this, because we realized that we didn't give them enough planning time, and that is just one of those things that we sort of realized in needing to accommodate survivors, that we need to be giving more lead time in planning there. So that's why we're doing it in April instead of in March. But we hope you all will still come back for the April session. It'll be a great one. And now I will pass things off to Karen. Thank you.
Hi. Hello, everyone. Hello, TBI Tuesday followers. Personally, I'm not sure what I'll be doing with myself in 2 weeks from now when I don't have a TBI Tuesday session to attend and keep on learning. Really happy to be here. My name again is Karen Farrington. I'm a Caucasian woman in my 50s with blonde hair, blue eyes, and glasses. I happen to be wearing a white shirt with some blue polka dots today. I want to also express my appreciation for all of you that are attending this session. These are quite a bit of work to pull off, and so thank you all for spending your time, these 3-hour blocks, to come and learn about some of the work that we've been doing during these grant periods. Next slide. So what I will be doing is taking us into a little bit of a deeper dive on the Criminal and Juvenile Justice Guide that you heard Julie talk about at the very beginning of our session. This was one of the products that came out of our work together as a team, and we'll move on to the next slide and I'll give you a little bit more information about that. This guide is really a compilation of a variety of tips and strategies that have been gained from learning from all of these other states that have been doing good work in the criminal and juvenile justice area. This guide was put together, kind of conceived by our work group through the Administration for Community Living Grant, but we look to a real strong thought leader in this community, and that's Judy Detmer with the National Association for State Head Injury Administrators, to really partner with us and be the author for this guide. It's written very much so for state lead agencies and state lead agency partners, but a lot of people can pick up this guide and use it and learn from it, but that is the primary target audience for the guide. The work was supported to get to the completion of this guide in sponsorship from 3 states, Colorado, Indiana, and Pennsylvania, who used the ACL funds to accomplish the purchase of this guide. And the most important thing about this slide is to let you know that the guide itself and every tool associated with it are on the National Association for State Head Injury Administrators website. And I think a link is being placed in the chat box as well. I'm going to approach this talk a little bit like I was a state that is just thinking about this work. I want to make a change. I want to be an implementer. I would, and this is what I would do if I were picking up this guide for the first time. Next slide. First of all, I would take a look at really what the components are of this guide. And there's 4 major buckets that are included. One is the overview of the criminal and juvenile justice system. You heard Reggie talk about the system earlier. We all know that it's a complex system. If I opened up this guide, it's going to help me to be able to start breaking it down through the demystification and the language that's included in the guide. The second section is really talking about specific target populations and maybe some that might be great places to start and some of the associated points of intercept. We've been learning a lot about that today. Looking at those topics would help me as an implementer plan my work and do some of my homework ahead of time.
But then I'm going to get ready to want to implement, and I need tools. I don't want to recreate the wheel. So in this guide, I'm going to find lots of examples and illustrations of the kinds of protocol that components that are used in the areas of screening, supports, and referral. I'm going to break these down a little bit further as we go on. And the fourth area of the guide really goes into sustainability and funding strategies. Moving on to the next slide, I'm going to first talk about some of the kinds of specific tools that you would find, and I would find if I were a new state just thinking about this area. I would know that I can go into this guide and read about lots of different types of training approaches that have been done by different states. And better yet, I'm going to have a lot of examples of those training curriculums. States like Indiana and Arizona have provided full slide decks along with quizzes in some cases, so that I wouldn't need to start from scratch, but instead could go into some existing training tools and really see what might fit for my state. I could take a look at psychoeducational tools. Something I think we've all heard about today is the importance of not only identifying people with brain injury, but helping them learn about brain injury once it's been discovered. Psychoeducational tools do that. So in this guide, I would find tip cards, wallet cards, to the extent of a 7-module psychoeducational session, curriculum that's already made. It's on the shelf, ready to use, to pull down and to implement in sites. It's full of content, exercises, and videos. So those are some of the kinds of tools I would find if I were checking out the guide in that particular area. You've also heard us talk today about screening tools like the Ohio State University TBI identification method. Some states have used that tool or a slightly modified version of that. And those are included in the guidebook. So I don't need to start a search. I have a lot of them right at my fingertips. There's sample MOUs, memorandums of understanding, and then sample content, consent and release of information forms that I know I would need to be using if I implemented it in my state. But I'd like to answer a quick question that came through the chat earlier, and it was from Samira. She asked about, are there tools for people with brain injury, but also tools for people that work with individuals with brain injury? So the clinicians, the jail staff. And the answer to that is absolutely yes. States like Colorado have partnered with the University of Denver to create that very kind of guidebook that helps those professionals know how to approach those individuals that have been identified with brain injury to have more successful outcomes. Moving on to the next slide, if I were in the planning stage and I wanted to better understand what my opportunities were for individuals to consider, I would pick up the guide and realize that there really are some priority populations that I can consider. Incarcerated juveniles has been talked about today. A huge matter because there is, seeing a different slide. Let's see here. Just want to catch up real quick. Can you go back one? Oh, okay, so go on to the next slide. And okay, so here I'm just going to talk about the fact that in the juvenile justice system, there's definitely different settings that we can work within. Diversion, detention, these have all been mentioned today. And what I might think about in this area is the fact that, that it might help me plan my outreach. I might think about, where do I have current partners already? Or where do I have some connections with some of these various juvenile or adult systems? Okay, moving on to the next slide. We heard today about the sequential intercept model. The guide that we've produced goes into a much deeper dive for brain injury using the sequential intercept model. In addition, it goes into some other types of content that are really important if I'm beginning to do work. I need to really understand how my partners talk about their work. And so, for instance, they have a model in criminology called the risk, need, responsivity model. If I spend some time in the guide really learning about about the RNR model, then I can take what I've learned from there and think about how that might apply to some of the messaging and the real key points that I would like to have come across when I'm talking with prospective partners. In short summary, the risk need responsivity model really looks at what the risks are for specific individuals that are coming into the system, what are their needs, and then what environments do they need to be successful and to see reduced recidivism. So I might really be able to talk about the various psychoeducational tools and how that might really be a fit in that responsivity. When we help people to compensate for brain injury, that can make a difference in this area of reduced recidivism and more successful outcomes. So by understanding this risk need responsivity and taking a look at how I can conceptualize it alongside brain injury, which is all in the guide, can really help me further plan my work. Moving on to the next slide, we will talk a little bit about how the guide highlights certain individuals that can be prioritized. We've talked about incarcerated juveniles, and there's a real philosophy around rehabilitation for this age group. So that could be a real important population for me to think about. Or individuals with co-occurring behavioral health conditions, because there's such a remarkable co-occurrence, and also people with brain injuries may be misdiagnosed and be believed to have behavioral health conditions when they're really struggling with brain injury. We can talk about the focus of female offenders. Something shocking that we saw in Colorado was a short female probation screen pilot that demonstrated 95% of those women had at least a lifetime history of brain injury. So that can be a really important population to focus in on. Offenders with childhood trauma, offenders with high criminogenic needs. Moving on to the next slide, I can then in my planning go on to think about the settings and partners that I really might be able to consider. In juvenile justice, we definitely see behavioral health units alongside adult prisons and jails. Those fit with Intercept 3 that Reggie talked about earlier. I, on the other hand, might have a really great connection and think about, I'm going to break into and do some work or partner with some specialty courts. I'm really excited about veterans or mental health or recovery courts. I could look at reentry programs. I could look at parole and probation. There's really not a bad place to start. I will say that there's absolutely some high impact areas. We've heard about that a lot today, and we've just talked about it on the previous slide. However, if I've got a potential partner, I'm going to go ahead and just get started, because the information that I can learn there, I can take on to other settings and really demonstrate the potential and the need with new partners in the future. Moving on to the next slide, we want to just spend a few minutes talking about what is like the full protocol and what are the components. If a state was to implement this type of work, what are the specifics that we would be trying to implement with our partners? And what you've got here is a list of the ideal, the real maybe Cadillac of if we could implement a really strong and substantive protocol, it would involve each of these 6 areas. First, we would start with training and educating the criminal and juvenile justice personnel, because until they better know about brain injury, we've really not laid a good foundation. We would be implementing screening for brain injury, but we would also be looking at some secondary screening, because if we know a person has a brain injury, but we don't know how they're impacted, we only know part of the story. So screening and assessing for impairment are really critical parts of the protocol. Next up is what you heard me mention about a few minutes ago, psychoeducation. Oh, sorry, one more back, if you could go back to the previous slide. And psychoeducation options are out there from very brief to very extensive. We've talked about that a little bit today, and that can be implemented as a follow-up to the identification of people with brain injuries. We can help them learn about what their brain injury means and how they can do things differently in the future to bring about a better quality of life. The next is that we can modify programming and help the staff within settings accommodate for the impairment. And you heard me mention that a few minutes ago, that there's a variety of strategies that help the staff really understand how to better interact with and get more follow through and successful outcomes from the persons that they're serving that have brain injury. And where it exists, referral to community-based services, you've heard it called resource facilitation today, resource navigation, case management. Where there are states that those services exist, a really important part of the protocol is to figure out how can we see people get referred to those community-based systems when they're exiting the system. And then finally, thinking through data collection and outcomes evaluation. This set is really the full protocol and what we would like to see implemented everywhere. It may be that we just have to start small. We may have a partner that is not necessarily willing to embrace all of this that I've just discussed, but they're really willing to think about doing some training and some screening with some secondary screening. Though wherever we start is important. The only caveat is that second bullet. If we only screen for brain injury, but we don't go on to really understand how the person has impairment, then we may be just collecting some numbers and we're really not getting into a place where we can help individuals. Okay, we're ready to go on to the next slide, and it is just a picture for you, and it's teeny tiny print, but I wanted to excite you, I suppose, with all of the different resources that are on the NASHA site. There are many, many of them, and they're all categorized, and they all go along with something that's been referenced in the Criminal and Juvenile Justice Guide. You heard me say a few minutes ago that there are guides that are specifically for jail staff or clinicians, and that's under the self-report tools and tips for juvenile justice on the left side. The link is there and you can go to it and really check out these resources. Many of them have been developed with grant funds, and therefore we're really jazzed about other people picking them up and using them and not needing to recreate the wheel. So moving on to the next slide, I just wanted to do a little bit of a wrap up and share that the guide also has a nice closing section about partners and cultivating and creating strong partnerships in communities. Again, sample agreements and memorandums of understanding. There's some section there about really thinking about producing a good body of evidence so that you're not just doing the work without being able to later tell the story. And then finally, some information about how important it is to tell the story, to do that messaging, and to be able to share the successes for the people that have been touched by this work. And then finally, there is information in the guide on capacity building. Next slide. With that, I'm not sure if we have time or not for questions. I'll turn that back over to Liz, but I did just want to say how honored I've been to follow, the presenters and the people that you've heard from today, and how very excited I am for you guys to hear the change maker that's coming up next.
Thanks, Karen. I don't see any questions just yet in the chat. A couple links that have been dropped in, which is great. Thank you for that. And then just, a thank you for this resource. It should be really helpful for states. So that was a really great overview. I appreciate it. I wonder if we should move on to Cheryl, and then if there are additional questions that come in through the chat, we'll have about 15 or so minutes at the end to have a further discussion.
Hi, everybody. I'm Cheryl Kemp from Texas. Do you have my slides? There we go. So in summary, my journey was I suffered anoxia in 1994. I have no feeling in my right hand or foot. Got to learn to walk again and cut my food and drive a car and all those things. I first ended up knowing about the brain trauma group, Office of Acquired Brain Injury in Texas in 2009. It was 15 years. And I began doing some speaking under their training. I was working for the Department of Assistive and Rehabilitative Services. And they began teaching me to speak, and I began speaking about coming back with no medical support from all kinds of disabilities to all kinds, blind services and deaf and hard of hearing and all the different emotional groups that we worked with too. In 2012, we had moved to San Antonio, and I was on my way home. I was chair of the Texas Brain Injury Advisory Committee, which is an advisory council to the Health and Human Services Commission in Texas. I was on my way home and got pulled over by an officer, and I dropped my driver's license because my right hand is numb. And when I told him that I often drop things, he said, "No, ma'am, that's a sign that you're intoxicated." I don't remember much of the night from the PTSD. He did beat me quite badly. He shackled my legs, handcuffed me behind me, and that's all I really recall. The next thing I remember is being booked into jail. I did spend the night in jail. I was charged with DUI and resisting arrest. My husband asked me what I thought was going on that night, and I said, I don't know. I said, the only thing I really remember was he was really tall and he was wearing sunglasses and it was dark. I said, and that's all I really remember. So I ended up having to, it took 2 years. 2 years later, Hays County, which is where it happened, had switched DAs 5 different times. Every time we got a new DA, they got a little surly about going back through the file and insisting that I was probably guilty, because Hays County has a policy of wanting a conviction for every arrest that they make. They still do. So in the summer of 2014, in that May, we were 23 months in. I have 2 licenses. I'm a CPA and I'm a certified fraud examiner. And my licensing boards were getting kind of grumpy about having to hear me tell this story because it hadn't been solved. So this comes to a point in the advocacy. Since the Hays DA would not settle the case or meet or mediate, that left it in our court. I have a daughter that's an attorney, and she said, let's win bigger than the courtroom. So we began looking at how to do that. The only way you can discuss a case is if it is solved. I mean, close, not solved. So I had to go before a judge and I had to be sentenced. I pled nolo contendere, but that technically means that you've admitted that you're not fighting the charges. So I ended up doing 6 months of probation and testified to the Texas legislature. So the key there is we had to take it into our hands. And the only way to do that was to be sentenced. And I will tell you that when that judge banged that gavel was probably the hardest moment of the entire journey, because I don't really remember too much of the night I was arrested. So in that year, that day when Robert Updegrove, the judge, gavelled me, he said, do you have questions? And I said, you cannot do anything to me anymore, right? And he looked really startled and he said, no. So the next day I was at the Texas legislature. I had been doing research for the ensuing 2 years between the 2012 arrest. And by this time we're into the summer of 2014. Here in Texas, you have to have the legislators have your bills in hand by November 1st before session starts. Our legislative session is every other year from January till either late May or early June. So I was in Elliot Neistat's office. He ended up carrying the bill. Because I had been chair of the council, I had not been able to talk about this to anybody in the brain injury community until my early September plea, and the case was closed. So I went to Elliot's office the next day. In my position as chair of the council, I had become aware of a video that we had. We had gotten HRSA funds for ATF training, and it had been used by the Austin Police Department under a captain named Art Acevedo, because Austin has a very high homeless population. And they were trying to divert a lot of people with PTSD. So by this time we knew I had PTSD, and I had gone to Elliot Neistat, and he was beginning to carry the bill. The next month, October of 2014, I had to resign as chair of the council because you can't speak in your own behalf if you're the head of an advisory council. So I had to resign as chair of the Traumatic Brain Injury Advisory Council so I could speak on my own behalf. That was the first time that the council heard about my situation. So session started, Elliot filed my bill. I ended up testifying on March 19th of 2015 to the Texas legislature about the experience. That experience, that law that was passed that year, which is House Bill 1338 of the 84th regular session, and my recorded testimony is what became the basis for that bill. It passed almost unanimously through both houses of the Texas legislature. And in May, the governor, its legislative status, and on June 17th of 2015, the governor signed it into law. He also moved it up. You can move the due date, the effective dates of laws up if they choose. He moved it from December of 2015 to September 1st of 2015. 3 agencies were charged with working with it. Department of State Health Services, which Texas has now reorganized itself, had to create the training. The Texas Commission on Law Enforcement gave the training, and the Office of Acquired Brain Injury set in to make sure everything was happening. That fall, the Veterans Office out of Waco prepared 656 packages on this training, and they called me after they gave it, because the veterans were all supporting it because of the PTSD angle. They said every one of the packets was gone. As I moved forward with this, I ended up, that law came into being. In the next year, I went to work at Wells Fargo and ended up speaking, and somebody in Congressman Hurd's office heard me and invited me to Washington. So in 2017, I made my first trip to Congressman Hurd's office and began talking about this law on a national level, because the more I spoke, the more we started hearing about more and more cases that had happened. So last year, 2020, just before COVID hit, I spoke to the congressional hearing on Brain Injury Day on the Hill, to the congressional briefing. I was part of that committee. Congressman or Representative Pascrell and Bacon carried the law. It did not pass last year. This case is the basis for the TBI and PTSD Law Enforcement Training Act, which they're hoping to introduce again this session. And I'm on the Public Policy Committee with NASHA, and we're contributing to that. So in all of that, I did a lot of my own work. This 10 points of criminal justice advocacy handout that you have the link to in the chat box, can you move to my next slide, please, where I start the points for the advocacy? So this is how I did this, because I did this pretty much all by myself. I testified to the legislature, and I knew what I wanted. What was my topic? My topic was my personal experience. They say you become an expert through 2 things, education or experience. So I began working through the Office of Acquired Brain Injury, and I started working with all these different groups, the Brain Injury Alliance of America, the Brain Injury Association of America, through the office itself, through the individual groups in the cities in San Antonio. So when you become an advocate, this had all started the day I took the plea in court so that I could discuss my case with the legislature, which I hope is a point most people never have to come to be sentenced, so that you can speak about your experience. So the question was, to the second point, I did not want this to happen again. I did not want this to happen to anybody else. And again, there's that statement, when bigger than the courtroom, my planning having to be sentenced so that could be used. To have attorneys tell you that there is no proof that you weren't drunk, and to have me challenged, my whole credibility, my licenses were threatened, my whole life was at risk. So as we made this decision, my daughter said, we're not going to win with Hays County. They're not going to settle. They're not going to take a plea. You're either going to have to plead guilty, or we're going to have to do it this way. Much as I didn't like it, we are already at a standstill, and you have to work within the system. You can't fight it anymore. It was really hard to accept that fact, but that's where we got. Next slide, please. So what are your resources? My resources, because I had been with the Office of Acquired Brain Injury and with the council, I knew how much there was, but when I got out of the hospital with my anoxia, we didn't have any medical help. So I began talking. I talked to other brain injury survivors that I had met. I would go to the council meetings. I was the first chair. I would actually, during our breaks, I would go down into the audience and talk to the people that were there, and to ask, why are you here? What do you need? And then I would start trying to hook them up with the right people within HHSC. I also started researching in other states. In June of 2016, an advocate named Bill Roof, who passed away last spring, was on the council with me in Texas, and he had moved to Massachusetts. His wife, Bobby, was a brain injury survivor. He said, come to the East Coast and let's see how this law flies outside Texas. So I did. and I worked with Massachusetts and New Hampshire and Maine, and was supposed to go to Rhode Island, but I was out of time. But it was really positive and really good. It also taught me that there are different ways laws are implemented in every different state. So in my website, which is cherylswords.com, I started to do a map as I was growing my speaking outside of Texas and having more and more input. And I couldn't continue that because I could no longer tell you that the people I'd spoken to at any speech came from every state, which is what I was trying to do, was show the states I had spoken to. So we began mapping, though, what we did with everybody in every place that we had. And so we could see. As we moved in through this, I had to learn to be flexible. Good example would be, as I started toward the law here in Texas, this was my law. I wanted a proof of ID on my driver's license or something to show, because my purse was in the trunk of the car when my husband and daughter finally found me the next day. They arrested me, but I don't think they knew who I was because they had no ID. So it won't pass in Texas, because at that point in time, we had a lot of mental health questions about, could you own a gun if you had anybody could prove you were mentally ill? So we didn't want to put that up there. So Elliot told me, he said that we won't win, but let's go at this as we have a gap in education. We have a way to train the officers, and that is how that began. That has stayed consistent as we talked across the United States. So I had to learn. They asked me that day in the state capitol, do you want a law or do you just want to be heard? And I said, no, I want a law. I don't want this to happen anymore. So that's the way we ended up doing it. I had to drop my own individual pursuit and my feeling of having been wrong, because I had to go the way Elliot and his legislative director told me we would have a law. And it did pass almost unanimously in both houses. So that was really good in this state. So as you approach your gap, you figure out where you can fill in, you figure out who you can benefit. The sixth point, keep notes. Notes are important. I must have talked to everybody I could find. I drove, I talked, I walked the Capitol there. In 2017, again, I made my first trip to Washington. I met with Congressman Hurd's staff. Since I was there, I looked up who was doing brain injury on the Hill, and I went on and met with Congressman Pascrell's office the first time. And I've continued that. I've been to Washington now 5 times. I've been as part of the Brain Injury Association of America's Brain Injury Day on the Hill. I've spoken at NASHA. I've spoken and just networked and kept going. And I meet some people in the same places. I talk wherever I can. I try to see whoever might be interested to know what's going on. The idea that the law is now very possible again at the national level this session is really good to hear, because I think it's very needed. The more I've spoken and the more people learn where I'm from and where I am, the more stories I hear. And it's hard. I had lots of know-how. I'm an ex-Texas State employee, so I knew about the funding. I knew about the Office of Acquired Brain Injury, but so often people don't seem to know. So these points, you'll notice the highlighted, the bolded are things that you could do. What are your resources? Be flexible, keep your notes. Next slide, please. Okay, what level are you working toward? When you're an advocate like I was, just on your own, every single thing I did, I learned from. Every single step brought me something else. First, we got the Texas law. Then I started speaking. And Congressman Hurd invited me to Washington. And then I started speaking at other states. I've been the keynote speaker for the state of Tennessee. I was in 2017 on this. They had me go point, counterpoint with a police officer in a police station. That was the first time I had been in a police station since the night I was arrested. But it was good. It was good because it was important to hear the other side too, because I realized this is hard to see. I do wish that the man had listened to me that night. I don't really know about, I've never gone back to ask those questions. We didn't have enough money to do a personal case too. So that was all right. You learn that so I guess the way I would say this is I am the person that this happened to. but this is not about me. This is about this happens to individuals. And while I'm an example and I testified to the legislature and we got a law in place, it's about everybody that this happens to. It's about the risk that this can happen and that you won't get hurt and won't have anybody give you an opportunity to say anything. So every single thing I've done has changed a little bit more. Every single time I speak, I learn a different angle, somebody else to talk to, something else to say, how to respond. Next is strength in numbers. There are people around you who can be supportive. Since it wasn't until October of 2014 that I could even talk to the council about, I had no opportunity for anybody except me and my immediate family to know about this incident. In 2013, I learned about a PTSD event and I called a friend of mine who's a psychologist and I said, I think I have PTSD because I cannot remember that night. She said, I know you have PTSD. I'll see you. And I said, no, I can't have it be a friend. I said, this has been hard, but it needs to be somebody I feel like I can tell every single thing to. They found me a trauma counselor in San Antonio who's an ex-FBI agent. And he was my trauma counselor. He was my PTSD counselor. And he helped me learn coping skills because you don't get better from PTSD as you don't recover from brain injury. So with brain injury, I know I can't ride a bike. I walk funny sometimes. I, only have one hand that's really dependable. But the PTSD, I don't know. It can be an angle of light. It can be a noise. A police car gets behind me and I still have to get off the road. That's what I was taught. He said, get off the road, get the lights from behind you, breathe. And that's what you do. You cope. So next slide, please. Advocacy can be hard. Breathe. This has been a good journey in that it's been positive. It's also been very hard because this is my life. I am normally a very quiet person. I laid out there on the line. It's recorded for everybody to see my testimony to the Texas legislature. I started talking about my life and how hard this was for me and my family. To put that out there was difficult, but if I hadn't done it, we wouldn't have the Texas law and the chance to have a national law or the TBI and PTSD Law Enforcement Training Act. Lastly, I would say grow your advocacy. Participate in the efforts of, as I've already said, the Alliance, NASHA, Brain Injury Association of America. Within NASHA, I've done several different things. I work with the Brain Injury Advisory and Leadership Group. Last year, I worked as a subject matter expert in the Advisory Technical Assistance and Resource Center. I've also been a speaker on criminal justice, law enforcement, and now I'm beginning to speak on advocacy as the individual who simply developed these steps. So thank you for hearing me today. We hope that you will download this form from the 10 points of advocacy and use it yourself. My contact information is at the bottom of that form, my website, my name, my phone number, my email. Please get in touch or get in touch with NASHA, with Karen Farrington, and ask any questions that you wish to. Thank you so much.
Thank you, Cheryl, so much. Really incredible story and amazing how you've turned it into these really tangible, helpful tips for others. No specific questions coming in through the chat right now, just a lot of people commending the work you've done and the bravery that it must have taken to get to this point. So thank you so much for sharing your story. There are a couple of questions that I was thinking we could maybe loop back around to that have either come through the chat or have kind of come up as people have been talking. So I'll just read them out loud, and then whomever on the panel or other speakers would like to chime in, I think that would be great. Diversion programs, for example, and other robust community programs can remove people early from the system. Where would a state begin attempting to develop diversion programs, and who should be at the planning table? Anybody want to address that? I don't know, Karen, maybe as you were talking through the guidebook, does it go into detail about diversion programs and how a state might want to start to organize that?
Yeah, Liz, I was going to suggest if Reggie wanted to start. I think you popped on and unmuted. And Reggie, if you'd like to begin, and maybe I can tack on to what you have to share about diversion.
Absolutely. So that's diversion, again, is one of the key things. And again, deflection, not having people in the system, diversion, having gatekeepers to be able to make decisions to officially not have a person go further. So a primary person is going to be your prosecutor's office. And it's also going to be, depending how your system is set up, but your prosecutor is probably the key person that can bring charging decisions or not. In places like Harris County, Texas, which would be Houston, for example, they have a specific diversion center, not for brain injury, but for mental health, but they have some standing orders that all of the prosecutors follow for certain kinds of charges if a person has serious mental illness. And so that person is actually offered to go to a diversion center, which is really a crisis stabilization center for services there in lieu of charges. There's also police-based diversion, where there's, again, often agreement between police and prosecutors, often defense and courts, depending on the system, to divert folks through what's called LEAD, law enforcement assisted diversion, or PARI, which are a little bit more specific around substance use disorders and persons who are experiencing homelessness. But again, that same kind of model can take place. But I would always first engage the prosecutor, and then depending on your system, looking at your courts, your defense attorneys, and your police as being really key at that level. I'm happy I put my email address into the chat. If you've got specific questions, happy to help you with them.
And the only thing I was going to tack on is understanding what's happening in your state, talking with your lead state agencies on brain injury, understanding what might be in your current state plans as far as initiatives go, who your memberships maybe includes on your advisory boards, may help you with some additional partners, and having the knowledge of what might already be in the works and in place in your states could be advantageous as well at this stage of planning.
Great, thank you. Staff turnover can sometimes be common in the criminal justice system. Any advice on how to manage this when it comes to advocacy, training, education, and sustaining relationships? Anybody want to chime in on a response to that?
Liz, can you repeat the first part of that?
Sure. Turnover can be common in this system. And so any advice on how to manage it when it comes to advocacy, training, education, and sustaining relationships?
I'm happy to start that discussion and others can jump in. So one of the things that I would always suggest is that if there's not a criminal justice planning group, to pull one of those together that has all the different stakeholders, in addition to advocacy groups, treatment groups, homeless, other kinds of services, and to put things into a charter kind of process so that when you do work, when you create policy or practices, that you write it up with what each agency is agreeing to do, so that you have some documentation of history and policy. And then if you have a new elected official or a police chief gets changed or whatever it is, it's not necessarily a legal document per se, but at least it's a start of saying, here's what we agreed to. And here's what happens if you pull out of this. Here's what happens to everybody else, all the rest of the system. We have to think about ourselves as air traffic controllers. What was happening with a person before we got him, what we're doing now, and what's going to happen next. And all of that should be written down so that everybody is saying, yes, this is our part in making sure this policy is coming into place. The other part, of course, is to try to do it through legislation, as Cheryl has done.
That's great, thank you. Is there anybody else from the team that would like to respond to the question about turnover and sustaining relationships?
Sure, I'd be happy to speak to that briefly. A couple of thoughts, and by the way, what Reggie said makes a lot of sense, because there is a ton of turnover in those courts. Frequently, judges don't turn over as often as anybody else. So if you can develop alliances with judges, they tend to be mainstays, and they're awfully powerful folks within the criminal justice system. So that's one thing. The other thing to think about is that frequently training young prosecutors. And the reason I say that is that many don't stay in the prosecutor's office, but staying with them after they leave, because they go to a variety of places, commonly criminal defense. That's not at all an uncommon pathway. And so if you build those relationships when they're in the system, you can grow them when they're out of the criminal justice system, and that could take you some very interesting places.
And this is Karen. I was only going to add that I think a strategy that's helped us, especially with the staff such as case managers or clinicians, is to really provide an opportunity for regular dialogue and checking in and bringing different sites together so that they can really hear what's working, what's maybe not working across different sites. We've done that with quarterly calls. We've prioritized in Colorado having a criminal justice specialist at our Brain Injury Alliance of Colorado. So he's available for ongoing technical assistance and training needs. But I think in those quarterly calls, we begin to see if there appears to be an issue emerging. And an issue emerging might be that their lead case manager is moving on to a different role. And we really need to be proactive and get in, offer refreshers, and try to keep everything intact.
Great, thank you. Another question I wanted to bring up, this has kind of come up in a couple different ways, but I wonder if somebody, I don't know, Lance, if you're willing to give some examples of accommodations, or Jennifer or Cheryl, with your lived experience, if you might have some ideas. I know, Jennifer, you were talking about Post-it notes, for example, and helping with your memory. We've alluded to training a lot. What are some of the accommodations that are recommended for individuals with brain injury in criminal justice settings? Some specific examples of that, just to give attendees an idea of what it looks like.
So I can make a few comments. I think the first issue, is the vernacular that is used in legal proceedings can be really challenging. The pace of legal proceedings can be really challenging with people, for people with lived experience. I think providing some written notes from proceedings so that people can have the opportunity to review those after the fact and study them and understand them in language that is familiar would be really useful. I think just the court setting is overwhelming. It's overwhelming if one doesn't have a brain injury, and it's even more overwhelming if you do. And so I think that the amount of noise, the amount of people in the courtroom can really be a challenge. And so I think it's a sensory overload issue. It's a cognitive processing speed issue. There's a website, and I'll put it in the chat box, from Ohio State University. Dr. John Corrigan did a very straightforward booklet on how to make accommodations. And I'll put that in the chat for everyone, for those who are interested.
Jennifer or Cheryl, would you like to share anything?
I think this booklet that Dr. Trexler was talking about definitely, sounds like it'd be something I would even like to read as far as accommodations. It was also educating my lawyer that RHI put so much time into educating him on how to, go to battle for me, so to speak.
I tend to be a note taker anyway. It's what I do to keep myself focused, which may be my own compensation from way back in 1994. It's attention span. It helped me to hide my frustration in court too, because my attorney was not very nice. He did things like say to people, we have to prove she's not drunk. And I had been at dinner the night, I'd had a glass of wine and a plate of spaghetti. That guy testified for me, and he said, what do you want her to do? I've told you she didn't have anything but one glass of wine. We've tied her time to 60 miles an hour. She was driving just fine. So sometimes I take notes so other people won't know what I'm thinking too, because I found myself feeling that the more I showed people that it bothered me, the harder he seemed to push at me. So I will say, you're right. It's very difficult in the legal system. You feel overwhelmed because you feel very, very alone. You've almost got this accusation because you're different. And that is where, when I finally got to talk to the counsel, it helped me a lot. It's really good if you have a mentor or someone you can speak to, because I don't know how other people felt. I felt completely confused by all the stuff I hadn't done. I didn't know how to answer any questions.
That's my case too. And you know, I was ridiculed by the judge because I look, so to speak, normal, and he didn't understand that it wasn't just about, it was in my head. And he would lash out at me several times. He threw me in jail for 3 days one time. And he didn't like the way I dressed. And I've always been a professional working woman, and I've always dressed decently. And he thought I should dress like in a sweatshirt and jeans. And I don't know, it just baffled me.
One thing I did learn, because I went back to work after this, and of course there's all kinds of entertaining stuff on my background when you pull a background report on me. So I no longer leave it for people to find. Because I consult and stuff, instead of that, I simply say to people, this is what you're going to find, and here are the dates. And it takes the power away from them, because I've laid it out there. I said, you know, the charges were dropped and on, but the whole point was, the only way I could get my life back was to take control of it. And that, I think, is a point a lot of people that are struggling with the system of any kind of disability, whether it's misidentity or anything else, they get very hesitant because the system is not always very supportive.
Right.
So I think I took that away. Now, you know, I will tell you, you can find my mugshot. You can ask questions. You can watch this video with the Texas legislature, and that takes away the ability what that judge did to you. He couldn't pick on me anymore because I'd already said to people, you want to know about it, go ahead and ask. Now there's a website.
Right.
But that's difficult. That's hard. And I'm I don't cry very often. It's very difficult to make me cry. I'm a lot tougher than a lot of people, I think. But I think that's what we want to build, is a protection for people, you know, because of these things, so that it hopefully doesn't happen. We teach people better.
Yes.
And that's not just the police officers, that's the whole system. It's the judges and the attorneys. It's everything.
Correct.
Yeah.
Yes.
Thank you both for sharing those experiences. That's really helpful. There was one question in the chat that I just want to read out loud. And maybe Reggie and Kyle, if you want to respond verbally to that, I think that would be great. And then that we probably our last question that we have time for. But assuming somebody's screened positive in the system in prison, how do you hold that system accountable for implementing the support that individual needs? And Reggie, I know you started to answer a little bit in the chat, but if you guys wouldn't mind just sharing that verbally, that'd be great.
Yeah, I always start by finding out what I can, asking about, depending on relationships and stuff, with what written policies are, what training is. So I want to look at it from that particular area, and then also what supervision is. So if there's policies in place, how are people being supervised? And then, you know, from there, it really is, a lot of it's going to be about relationships, unfortunately, but there are ways to really look at, you know, think about it's paramilitary. So jails and prisons are a paramilitary system. And so they'll follow that kind of order and those chains of command. And you can also, of course, try to get onto roll calls and to be able to offer different kinds of training, offer suggestions for what kinds of policies might be helpful. So all of that kind of stuff. And in the end, if it fails, and Kyle talked before about a couple of different lawsuits, but the ADA is very specific about accommodations and supports. But Kyle, I'll let you talk more about that.
Yeah, the ADA's got requirements around what kinds of accommodations people have to, what kinds of entities have to make. I am not an expert on what kinds of lawsuits have happened around, specifically around traumatic brain injury. And so I like this idea of, you start by playing on the better angels of prisons and jails and understanding that, if people are educated and understand that there is, trauma that happens to people's brains, and that creates areas of issues, and that actually, if you do these kinds of accommodations, you'll understand where these behaviors are coming from, and you actually could make the prison a better place. We do this around mental illness too. But in the end, if you're not getting that kind of response, there are avenues to look at the Americans with Disabilities Act and to look at that angle. And I just want to say, I mean, you can't underplay listening to Jennifer and Cheryl, just be able to have the bravery to talk about their story. And I think it's so true that when you look at folks and you see Jennifer and Cheryl just sort of standing there talking, and you don't necessarily see someone sitting in a wheelchair or see someone looking different, that really makes it hard for somebody who doesn't have exposure to these kinds of issues to understand that there is something different and in the brain. And that's the kind of education and hope that we have to keep working towards. And I just really appreciate the opportunity to be a part of this, and to, I'm glad that I'm able to contribute to this, but I really appreciate being able to learn from folks like Cheryl and Jennifer. Thank you, guys.
I would like to second that, Kyle. I think it's also a liability in a way, paradoxically, because just like Cheryl and Jennifer stated, the people look at people with traumatic brain injury, and most of the time they, quote, look normal. Moreover, sometimes people with brain injury aren't aware themselves that some of the difficulties they have. So it's very difficult for them to advocate for themselves or to educate others about their difficulties, because they may, how the brain has been affected may affect their own awareness of their difficulties. So it's a double-edged sword.
All right, everybody, you just want to bring everybody back. Thank you so much to everybody. That was a great way to wrap up the day. It's been, wow, just a lot of stuff today. We're very fortunate to have the speakers that we had. We've got, the next thing is a real-time evaluation. I think Connor's going to put that up on the screen. There it is. If you take a few minutes and do the real-time evaluation right now, while I wrap up some other things and to tell you about next Tuesday's session, the 5th and final TBI Tuesday in March, but this one's in April. So please remember that you cannot register just because you were registered for today. Just because you got into today doesn't mean you're going to get in next week. You need to register for each one separately. And I encourage you all to register for the last TBI Tuesday session this year. This one is focused on maximizing the effectiveness of advisory boards through full participation. A point about this one, it is really focused on engaging people with TBI, survivors, in every aspect of your programs. It's not just about advisory boards. It's really about how do you best engage survivors? How do you, as survivors, how do you prepare for your engagement, and that, say, taking it from both sides. So very exciting session. Should be very, very interesting. Next Tuesday, April 6th, same time, 1 o'clock Eastern time. And a reminder that we will be posting the recording of these sessions along with the slides on the ACL website. There's, I think, the first TBI Tuesday, the Monday one, Monday one, first part of the week. The first TBI Tuesday from the beginning of the month is up on the website already. And I want to give a huge thank you to all of our presenters today, to our federal partners, Kyle Smitty. Kyle, thank you so much for joining us from the Department of Justice. Regina Herder from Policy Research Associates and SAMHSA's Gain Center. Thank you so much for being a part of this. And thank you for not just presenting, but staying and listening to the whole presentation, because as Kyle said at the very end, it's great to make some connections. It's great for everybody to hear all parts of the landscape and the perspectives of everybody. It's very, very valuable. A huge thank you to our grantee presenters, and not just presenters, but the people who put this together today. From Indiana, Peter Bespikos, Lance Trexler, and Laura Trexler. From Pennsylvania, Julie Myers, and from Colorado, Karen Farrington and Liz Gerdeman. And I can't say enough about a huge special thank you to Jennifer Scott and Cheryl Kemp for sharing your stories, for sharing your perspectives and your experiences. This is the heart and the meat of what we do, and it's really an honor to have you with us today. Big thank you to ACL staff, Dana Fink, Rebecca Ellison, Wilma Roberts for their support, and the TBI TARC staff, Judy Detmer, Maria Crowley, who many of you know, and Terry Gamacho Gonzalez, and of course our superhero Connor Bailey for handling the webinar logistics. That's terrific. And I think, are we done with the post-webinar evaluation? We'll leave that up for a minute, and we just want to say thanks to everybody, and we'll see you next week. Have a great rest of the week. Bye.